The broadcast is now starting. All attendees are in listen-only mode.
Good morning, everyone, and welcome to our Safe and Calm webinar for September 23. Today and every day, we want to acknowledge your continued work to serve residents and support your staff through the pandemic. And we here at Leading Age Michigan have been working to support you during this very confusing and complicated time. And this past week or so, actually 2 weeks, have been very confusing, unfortunately. Today we'll be using our usual agenda, and we will start with an advocacy update, followed by a situation update, which has changed a bit. And then we will do a very brief review of where we are with the visitation guidance. We will follow that with an overview of cohorting and end with a few nursing home only updates. So with that, we will turn the presentation over to Dalton, our Director for Public Policy.
Good morning, everyone. We do have a couple of things to touch on. I put this slide in last night, and things changed this morning as the budget came out about half an hour, 45 minutes ago. So I have some brief details coming out of what I've read so far, but I did want to remind members that the Michigan legislature is only scheduled to go until the 24th. They will go until the 31st if they need extra days to pass the budget, but the budget came out, as I said, and it is scheduled to be passed today by 2 o'clock or so. So this thing's going to be moving really fast. This budget was negotiated behind closed doors in a very kind of secretive process. Not a lot of people knew what was going on, but I do want to say that we came out relatively unscathed, and there's actually some positive news to share on that front. But I did want to also note that after the 24th, policymakers will be going back to their districts for in-district work periods to campaign or just to support the election. So that is a great time to reach out to your local representatives and contact them to get some advocacy work done or just to check in. It's always good to have that kind of a presence. Nationally, as I said last webinar on Friday, they're scheduled to go until early October, but this largely depends on the fifth stimulus package. I haven't heard any updates since we last spoke. There was a bill that was in the House that was kind of a negotiated bill between the Senate and the House, but that wasn't really done with party leadership in mind. So we'll see where they're going on that. But everyone except the Senate has made public statements that they'd like to get something done quickly here. Before we move on to any other updates, I do want to share some quick details from the budget that I've read. The Centers for Independent Living get a boost. There's an actuarial adjustment for home and community-based services of 2%. There's funding in there for SNF pre-admission screening and annual resident reviews for mental health. There's $150 million to provide a 3-month increase or extension to the $2 an hour wage increase for direct care workers, following the same criteria that it always has. So that will be extended for 3 months. There's extra funding to expand Healthy Moms, Healthy Babies, which you know is the governor's kind of project to help out mothers and babies by allowing them to, or giving them greater access to expanded Medicaid benefits. There's a flat $2 million increase for senior community programs, and there's $40,000 for a senior call check pilot program, which is where the state will be just reaching out to call seniors and contact them to make sure they're doing all right. And then Medicaid managed care will be going to a single preferred drug list. And there's also $20 million allocated in coronavirus relief funds for reimbursement of PPE costs for SNFs. And this will be allocated to SNFs on a per bed basis. And then interestingly enough, all of the non-used coronavirus relief funds that would have expired on December 31st will actually be transferred on December 30th of this year to support unemployment. So if we don't use all our coronavirus relief funds, they're all going to be dumped into unemployment before they would have to be taken back by the feds. Another interesting piece is that the nursing facility cost reporting policies that were in the last budget and boilerplate have been deleted. From that boilerplate, this would have required DHHS to use a prospective effective date if they issued new policies affecting facility cost reports, and allow a retroactive date if required by law. That has been removed, so we're back to what it was before. I think it was last year or 2 years ago. All right, let's move on to the next slide. Oh, also, our rates aren't being, the Medicaid rates are being held true. There is nothing affecting the variable cost limit in this budget. I know the last couple of years, there have been various different things in there to try to remove things or try to affect that rate. I don't see anything in there for this so far, and I'll be catching up with everything on Friday for everyone. So moving on, this is just an update on the liability bill that has moved out of committee yesterday and is on the floor today. I do expect it to pass similar to the last one. There hasn't been as much opposition by political figures in this one. The advocacy groups that were against the bill before are still against the bill. I do anticipate a vote taking place soon. And it is also very important to note that the dates in this liability bill are for any care provided between March 9th and July 15th. So this is really for that first wave of COVID, and we're still looking for some assistance on a second wave should that come. And I attached a link here for the bill summary of the document. So if you want to read it, you can read it. So an interesting thing to note that was with the CMS visitation guidance that came out last week. This guidance also expanded what states or what providers can apply for CMP funds for. And so with this guidance, CMS opened up visitation or opened up the use of CMP funds to help facilities facilitate in-person visits. So you can apply for tents, for outdoor visitation, or clear dividers, just like plexiglass or similar products, to help facilitate visitation. Funding is set at a maximum of $3,000 per facility, similar to the technology CMP fund thing, application process. And then MDHHS reached out to us and wanted us to let you know that the state will be coming out with a state-specific application. They do know that CMS sent out an application form for these new CMP funds, but they want you to hold off to use their state-specific form because last time with the electronic devices stuff, it caused a kerfuffle over at the state and got a little messy and caused delays. So they'll be releasing a state-specific application shortly for you. Over the weekend, I believe on Saturday, Health and Human Services issued the PRF reporting guidance. These are the provider relief funds at the federal level coming out, that second distribution of about $2.5 billion. They issued a guidance on what you have to report back to them. This guidance applies to all distributions except the nursing home infection control distribution, which will have a separate reporting guidance. So take that infection control piece out, and this is what's left. And so providers must report the use of funds for healthcare related expenses attributable to coronavirus or to lost revenues, and we'll be covering what those are in the next slides. And they also noted that the reporting system, which was supposed to open in early October, will now open in early 2021, but that first report is still due February 15th for the funds used through the end of 2020. The guidance is here in a link, and the summary is here in a link. And I do want to let you know that if you're on the call, I did reach out to Leading Age National about what hiring staff means for these funds. And they said that they are still actually in the process of communicating with HHS/CMS on this. And so this is something they're going to be asking them. They do have a conversation with them scheduled for Thursday. So they'll be reaching out to them, as they also feel that it's very broad. So stay tuned on that little bit there. So moving forward, the next slide will be healthcare related expenses attributable to coronavirus. This is one of the categories that you do have to report using the system once it's out in early 2021. You have to report the expenses in one of two categories: general and administrative expenses and healthcare related operating expenses. And providers are advised that only those expenses not reimbursed by other sources should be reported here. Providers who have between $10,000 and $499,999 in aggregate of these funds can report their expenses in aggregate, but those with over $500,000 need to report their expenses in detail. And the guidance itself goes on to further explain specific examples of the category. I won't be covering those on today's webinar, but please refer to the guidance if you have more specific details, or feel free to reach out to me. Lost revenues. So this section, in this reporting section, is relevant if all the funds that you received were not consumed by your expenses. And so this is defined as the lost revenues of the year-over-year net patient care operating income. So patient care revenues subtracted by patient care related expenses. And it's important to note that this approach that HHS is using is more limited than previous guidance, which permitted any reasonable method of estimating lost revenue. So this is a little more specific and will require a little more calculation on your end before you report. Here's really important dates for these reports. October 1st was the previously announced date for opening the new reporting system. As I said, this will be delayed until early 2021, and we don't have a specific date yet. February 15th is still the deadline that you need to submit the first report, and July 30th is the deadline to submit a second and final report for your 2021 revenues and expenses. Moving over, there is a bill that was introduced in the House that was supported by Leading Age and Leading Age Ohio, as it was introduced by a representative from Ohio, that would allow the HHS secretary to extend the current 5-day limit for respite care coverage provided by Medicaid to 15 days in the event a hospice patient's primary caregiver is unable to provide care due to illness or isolation during a public health emergency. And it would also allow respite care to occur outside of an inpatient setting. These flexibilities are something that Leading Age as a whole has been asking for. We're very excited to see this bill be introduced. It's got to still go through the process, but it's a step in the right direction, and you can see a link to the bill text right there if you're so interested. It's kind of a summary version of it. So it's an easy read, as these bills can get kind of complicated at the national level. This is a reminder, since I have been talking about the revised regulations for COVID-19 employee leave relating to the Family First Coronavirus Response Act. We do have a training coming up on this that should be very insightful and helpful for those who still have questions, or those who want some more specific guidance, or just want to view a really good piece of education. This will be taking place on October 2nd at 11 a.m. and we're happy to have our friends over at Dykema. Robert Boulin will be presenting for us. So it's a great opportunity, and I certainly urge you to attend if you do have any questions.
All right. Thank you very much for all of that, Dalton. Before we get into any questions, each year Leading Age Michigan is thrilled to spotlight the new and innovative programs and services displayed by our business partners at our Solutions Expo during our annual conference. During this historic and challenging time, we would like to celebrate our business partners who have maintained their commitment to our members during our short delay. Please thank our business partners by supporting their programs when you are in need of their services. All right, so I do have a couple questions for you, Dalton. The CMP funds are not accessible for HFA and AFC, correct?
For the visitation funds, yes. I believe they are only accessible for SNFs.
Okay. And then this is more of just a comment. Thank you for the update on the meaning of hiring staff definition. Look forward to an update after the Thursday meeting.
Excellent.
And then how do we log on to that October 2nd webinar? That will actually that's taking place during this webinar, correct? It's still just the Safe and Calm. It will just be our October 2nd. So it will be next Friday's webinar is when we will have him on to discuss all that, correct?
Yes, that's correct. Robert Boonin is going to do an overview of the guidance during our Safe and Calm Friday webinar on October 2nd.
Yep, so you won't need to do anything extra. Just log in to this webinar as usual. All right, it looks like that was actually the last question, so we can go ahead and move on.
Sounds good.
Okay, thank you. We're going to do a very quick situation update here. This morning, we are going to return to one of the graphics that we have been tracking off and on for a while. It is the Financial Times display of daily deaths across the globe based on a 7-day rolling average. We first started looking at this graphic in April, and the U.S. at that time was responsible for about 33% of all the deaths. And then, of course, everything improved significantly in the U.S. at least, and in the world, across the globe as well. And following a second brief surge, you can see that the U.S. is pretty stable, and that the South American countries and India are carrying a really high proportion of deaths right now. So this next slide is the CDC map that compares daily caseload among the 6 Region 5 states. So as we look at this, we're comparing Michigan against some surrounding states, and you'll note that these are raw numbers that are they're not adjusted for population. And we've shown some of this before. Michigan is the light blue line, and it peaked early and then stabilized quickly. And although we've had some increases in the past several months, we continue to compare really favorably well to these other states. And it's important to note that Illinois and Ohio have much larger populations than we do, but the other 3 states in the group do not. The other 3 states are smaller than Michigan, and yet we fare in terms of these raw caseload numbers very well to them. And when we look at the map in terms of caseload, Michigan is doing pretty well comparatively. So this is our ongoing caseload graphic. And again, although the data is moving up and down a bit, you can see that it's relatively stable. And while caseload is not necessarily going down, there is definitely less transmission here than in many other states. With the deaths that we measure over time, remember that these are 7-day rolling averages for only the last 60 days. We note that there's maybe a slight trend upward since the beginning of this 60-day period, but we compare equitably, definitely not better compared to average death rates in other states on average, but definitely equitable in terms of that comparison. And last, but certainly not least, we'll turn to the MySafe Start map. Yesterday, I had checked the website twice, and the map was completely grayed out both times. And then this morning, I checked it again, and lo and behold, it turned purple. So the MDHHS statement about why that happened is included at the bottom of the slide. So apparently they have added one whole risk level. They changed the naming of the risk levels. Apparently they've aligned this somehow with national thresholds. They changed the thresholds between each risk level themselves. But what they haven't done is explain how these changes align with the testing frequency that nursing homes have to use. And of course, there's no real definition of how these risk levels are computed by MDHHS. So that's another question going back to the state today to figure out how we're supposed to think about this new map and its new colors. The other thing is that apparently now the upper and western part of the state have higher rates of transmission than the eastern side. And if you remember last couple of weeks, it was the eastern side that was at high risk. And of course, the Lansing area related to Ingham County is undergoing some outbreaks. So we'll be looking at this hopefully with the state in the near future. Our test positivity rate across the state is 3.1%. And that's compared to a rate the last time we measured about a week ago was 3.5%. It's also, I think, important to note that there are only 5 counties in Michigan that have more than a 5% test positivity rate. So if we were using the CMS guidance for testing, those are the only 5 counties that would be doing weekly testing right now. So compared to what the CMS thinks we should be doing, it seems like we're doing fairly well. So now we're going to move on very briefly about the fairly controversial visitation guidance. So just a brief update on how we got to where we are. On September 10th, the department issued its visitation update that pretty much focused on outdoor visitation exclusively, along with a few requirements such as the need to oversee directly any visitation. And they also updated the definition of medical provider contractors as essential workers, which I thought, was a good piece. And then shortly thereafter, they issued a very brief set of visitation FAQs. That same week, CMS issued its commission report along with a subsequent QSO memo mandating visitation indoor and outdoor on September 17th. So at that point, we communicated with the department immediately, and since that time, they've spent a couple days digesting the essence of the order. And then finally, Laura issued a letter asking providers to hold on implementing until they clarified with CMS. So on Monday, CMS held a conference call with providers, and Evan Schulman, the director of the nursing home group in the QSO area, spoke about the new guidance and the importance of it in supporting seniors in nursing homes. He noted that this guidance replaced all other CMS guidance on visitation, which means that the recommendations to states in the CMS reopening guidance no longer apply. So those recommendations that kind of gave some ideas to the state about how to do visitation based on where they are in phases, none of that applies any longer. There is a focus again on outdoor visitation. It is to be used whenever possible, but indoor visitation, when conditions are appropriate, must be allowed. And that language is very, very direct in this letter. They are also focusing on additional use of CMP funds to support safety protocols. And the director ended the discussion with some thinking about the fact that state laws cannot conflict with federal requirements and guidance. And in order to work through that, they're going to be communicating with states to get alignment. So we'll all be on hold for now, but again, we will continue to suggest that nursing homes work to develop their plan for reopening visitation, create an implementation and communication plan and all your related policies, et cetera, in the meantime. Because the only way that CMS changes, these changes won't happen, is if CMS withdraws the protocols in that letter. And at least at this point, they do not seem quite ready to do that. But they are talking with states about how they're going to implement this. So let's pause because visitation is such a big issue here. Let's pause and see if there are any questions about that at this point.
I just have two questions so far, both fairly similar, I guess I would say. CMS was very clear that we should follow their guidance and not the state, that the feds trump the state. So why would we not use the county positivity rate to determine our frequency of testing rather than follow the state that says weekly, no matter what?
Because the rule, if there is no one rule that always applies here, except you have to follow the federal guidance. And if the federal guidance says that you can't disallow visitation, if the certain provisions have been met, such as your in-house transmission rate or other issues, you can't deny someone's resident right to visitation. And that's what they have put in that guidance. So the state can't exceed that restriction because it's a resident right. That's the way it was written. However, in terms of testing, for most counties, except all for 5, the CMS guidance would say that you only have to test monthly. But if you test weekly, you are meeting the criteria to test monthly. There is no restriction on the number of times that you can test. So you are meeting the requirement, and the state does have the right to enhance certain requirements as long as the CMS requirements are met. So it's a different situation entirely.
All right. This is more of a comment. We listened in on the CMS call and felt CMS stated clearly that CMS should be followed instead of state guidance.
I believe that too, but I also heard Director, and believe me, I'm all for this. I don't want to stop this at all. In fact, we're kind of trying to push the state to do this. It isn't that we're trying not to, but there is some consideration for the fact that they put an immediate effect on something that is going to take the state a few minutes to think about it. And at the end of the call, I heard that they're going to work with the states individually and try and figure that out. I don't think that there's going to be a surveyor surveying anybody in the next couple days. It would be nice to open up visitation for these poor residents, and we're still pushing the state to do that. And not only are we pushing the state to do it for nursing homes, we want them to do it for every level of care. However, they seem to be digging in their heels a bit, and we don't know how this is all going to play out, but I would believe that once they communicate clearly with CMS, I don't see CMS backing down from this. They have a huge commission report supporting opening visitation as long as certain precautions are met. So yes, it is a requirement, but we don't see any immediate, we don't think there's going to be any benefit from you opening visitation without knowing how the end result is. But yes, the guidance is as it's stated, but there was a qualifying piece at the end of that conference call where it said that they would be communicating with states about how to implement it and how to get that state to align with the guidance.
All right, so I've had a few more questions build up here. The CMS guidelines are specifically for nursing care. Should this apply to assisted and independent living as well?
We want them to, however, at this point, that's completely under the authority of the state. We do think that once the state understands what it's going to have to do for nursing homes, that it will go ahead and apply those rules to other settings as well. But again, I can never anticipate 100% what the state's going to do, but that's what we're pushing them to try and get them to do.
All right. Meanwhile, the HFAs have to continue to follow the stricter guidance from MDHHS. Will there be movement on this?
We hope that there will be, but at this point, we don't know.
Is the state looking at making IL and AL restrictions consistent with SNFs?
They have not really responded back to us about this. We talked to them mostly on Friday and Monday, and actually a little over the weekend, about the need to open up visitation, and they were reluctant to do that. And it was a bit of a surprise to us, actually, that they thought that they could get around doing it, because it's very clear legally that CMS is in charge of the rules here. But they have not really talked about this since they sent out their memo to the nursing facilities, asking them to delay implementation until they communicate with CMS. So we're still kind of at that juncture. We have asked them to align this with the other settings, but we have not heard back from them about that at all, because they don't even want to open it up to indoor visitation.
Okay, so are the surveyors going to cite us when they come in if we are following CMS guidelines and not MDHHS for visitation, or cite us for not following the federal regulation if we are following the state?
I don't see how they could possibly do that, since the memo came from Orleen Hawks at Laura, who is Larry Horvath's boss, to withhold. And even if they hadn't sent out that memo, I think that there in the guidance, there's a 30-day period to train the surveyors about how to look at this. So I would anticipate that you probably won't even see anybody reviewing for this guidance for several weeks, even if they hadn't put a delay on implementation.
Okay. Can you clarify that outdoor visitation can continue if there is a staff positive? I thought that no visits were allowed if there was any positive test result.
That's a conflict between the CMS and the MDHHS guidance. And so right now, everyone should be following the MDHHS guidance, which says no outside visits or indoor visits ever. If there is a staff, if there's a positive case in your facility. However, of course, there are those exceptions to that for indoor visits. I misspoke earlier. It's the CMS guidance that says you can have outdoor visits even if you have an outbreak. So I would ignore that for now, because right now we are kind of waiting for some communication, and we're following the state guidance.
All right. It looks like I haven't had any other questions come up, so we can move on.
Okay. So today we're going to talk a little bit about cohorting. And I have to say that we get a lot of questions about cohorting and what to do if A situation or B situation. And this was one of the hardest things for me to go through, because we have a pretty good sense of what the state is doing, and at this point kind of expects, but unfortunately the guidance really doesn't follow that. The written rules and regulations don't follow what the state's doing in several different kinds of areas, so these rules are vague, they're confusing and conflicting. But we thought we should take some time and review what we do know, where the gray areas are. It might be helpful to go through that. A lot of this is still really hard because, especially for the nursing home side, because these surveyors seem to be citing for situations far beyond the written requirements, and CMS seems to be supporting them. So it's really hard to figure out all the time what we should be doing, but we're going to give it a shot. So one thing we also want to note, go back please, Blake. One thing we also want to note is that the CDC expects non-nursing home providers to basically follow the same guidance as nursing homes in terms of infection control precautions and care and services for COVID-positive residents to the point that they can, especially if they have COVID-positive persons in their facility. Often the state guidance for HFAs, AFCs, and assisted living is not explicit, but they are both directed to Executive Order 179 that talks about dedicated units. And they're also directed by HFA, AFC guidance to the CDC, particularly to the guidance titled Preparing for COVID in Nursing Homes. So facilities should be familiar with those two documents, nursing homes and other residential facilities. There are a lot of precautions in the CDC guidance, and some may be hard to live up to. They often add the words "if possible" to their guidance. But if a facility doesn't live up to that provision, they would have to have strong documentation that there's a good reason why not, especially if you're a nursing home. Probably less necessary if you are another kind of residential setting. So, whoops. We're on the wrong slide. Moving forward. Okay, here we are. We're going to start with the information on what constitutes a dedicated unit or a COVID care unit based on a CMS CDC training program. The link for that program is listed here on the slide. So each nursing home is expected to have a plan to cohort residents in case of emergency. So even if you're not housing COVID-positive residents right now, or you plan to even cohort them in the future, in other words, if you plan not to take COVID-positive patients, you still have to have a plan, especially if a major surge returns, you need to be ready. And nursing home surveyors will be looking at whether or not you have dedicated staff in your dedicated unit, if it is occupied. We know this is a hard part for many facilities, but you will be cited for it unless there are some extreme circumstances. So this should be applied to any dedicated units in residential facilities as well. So I'm not going to go through the details of this training on cohorting as it is, because basically these are things that we've all talked about and we all know. There is a bit more detail in the training and about the different kinds of units on how you can set them up if you want to review that. So for nursing homes, the guidance for care of COVID-positive admissions come from several sources. It's very confusing array of requirements, and sometimes it makes our heads spin. It was somewhat gratifying to know that the Federal Coronavirus Commission, who just recently issued their report, identified much of the confusion and issues in nursing homes come from duplicated and conflicting guidance from multiple sources. And another example of this is that Leading Age has reported that they are again reviewing, CMS is again reviewing some of their training materials that they just recently published because of some of the content conflicts with CDC guidance. At least there's some acknowledgement that the right hand doesn't always know what the left hand is doing. So this slide is about whether all nursing homes need to have a dedicated unit. That's where we're going to start at the base. The original executive order that set up regional hubs, and I think that was 2020-50, required all residential entities to make a concerted effort to develop dedicated units. However, that provision seems to apply only to nursing homes at this point. So every nursing home is required to have a plan for COVID residents, including how they would create a dedicated unit. And CMS refers facilities to also align with state or local guidance, which we would believe would support the executive order, which is now 179, about regional hubs and how they're used. The CDC also requires a plan and to identify a potential space for that dedicated unit. So nursing homes can be cited for lack of a plan. What is unclear to us is if they have to have an active dedicated unit, even if they have no COVID residents or anyone in observation. That doesn't make sense to us, but we haven't heard anyone's been cited for that. So for other residential settings, basically the CDC is silent about taking COVID residents or placing them in a dedicated unit. At least they're silent in the guidelines that they write specifically for assisted living, which is the link at the top of the slide. Remember here too that they do encourage providers to follow the nursing home rules for infection control issues during the pandemic. So we've listed the links to both sites here, both for the assisted living directly guidance, which is really very high level, not very directing about what you have to do in care of a COVID person, and also for infection control guidelines for long-term care, and both the Bureau of Community and Health Services guidance and the CDC encourage non-nursing homes to follow that. And of course, when you're not sure what to do, facilities should start to problem solve with a call to the health department. So if you're not sure what to do about trying to create a place, or if you end up with a COVID positive resident that doesn't need hospitalization, we know that that has been a really, really hard issue for a lot of our members. Start with a call to the health department. But we do have to admit that the state guidance is not very clear or helpful when it comes to non-nursing home facilities. Okay, moving on to placement and admissions of COVID positive persons in nursing homes. There's always been the requirement that nursing homes can only take admissions that they can care for in terms of capacity and capability. And that holds true for COVID positive residents as well. If you cannot maintain transmission-based precautions in a dedicated unit, a nursing home cannot take the admission. And that criteria is supported by the 2 QSO documents listed here. And the executive order states that if you do have a dedicated unit, that is where you must place them as long as there is capacity. And if there is no capacity, you must attempt to find another facility and attempt placement. Those are words that we have a little challenging with, because we also know that if you don't have a dedicated unit and capacity and you have a COVID positive person, you're likely to get cited by the surveyors. So that kind of is a dilemma for you as well. And you kind of just have to work through these cases one by one. We believe that it would be an extraordinary circumstance where you would not get cited for keeping a COVID positive resident if you weren't serving them appropriately in a dedicated unit. For other residential settings, many of the same rules apply based on the CDC guidance. And the Executive Order 179 states that if you have a dedicated unit, that's where you must place them. It doesn't necessarily say that these lower level settings have to have a dedicated unit, but if you do, you have to have them placed in them. And if you don't have a dedicated unit, then you have to, again, attempt to move them out of the facility. And unfortunately, you cannot move them to a regional hub. And that's in their thinking currently as they're rethinking the regional hubs. They still want to reserve those beds for hospitals and nursing homes, which we find is a challenge. So it's unclear what providers are supposed to do in this instance, and we have asked them for more clear guidance about that. But there's no provision here that clearly says you cannot serve them in a private single room if you have no alternatives. And we're not aware at this point of anyone getting cited for this, for those non-nursing home settings. For nursing home admissions of non-COVID residents, You can see that QSO 2028 revised is pretty much the guiding directive here. That narrative states, if possible, you must create a separate observation unit for new admissions and place them in transmission-based precautions for 14 days. And although it provides options other than placing them in a dedicated unit or single room if those things don't work, the reality is that a nursing home will get cited for that by the surveyors. For non-nursing homes, the FAQs from the Bureau of Community and Health Services refer again to that basic CDC guidance that is again included here, and they recommend an observation unit as well. So the frequently asked questions also state that facilities can quarantine new residents and persons coming from the hospital, but it seems that those decisions have to be based on medical guidance and orders from the local health department if we're talking about these settings. So full transmission-based precautions, of course, are expected for those scenarios as well. So basically, the CDC requirements are that COVID positive, COVID suspected, and those under observation have to be separated from COVID negative or COVID unknown residents. Observation and suspected status, of course, cannot be put with COVID positives. The observation status does require full transmission-based precautions, including N95 masks. That means that most facilities who are accepting admissions have to have 3 separate areas: COVID negative or unknown, COVID exposed or under observation, and COVID positive. And we know that is a big challenge for facilities. The CDC has also said in some of its webinars that COVID persons under observation could share a room if necessary, but we have a sense that perhaps you could get cited for that, but we have not seen it. We have not seen that in our experience. And remember, we obviously don't know about all the citations that are occurring, but we get a sense of them. And the MDHHS guidance is silent on how providers should deal with COVID positive residents if other avenues are not available and the facility has either not capacity or perhaps they don't have the presence of a dedicated unit. So if you only have 1 open bed, how are you going to create a dedicated unit that way? I mean, that's got to be a real challenge. So, and now we get to the real controversial piece: persons leaving the building for personal or medical appointments. In nursing homes, sad to say, they must be placed in an observation unit with full PPE based on citations currently being issued by the surveyors. The CMS 2028 nursing home revised guidance is a QSO letter. States they must be placed in isolation in a single room, but preferably in an observation unit. But practice says you can forget the single room part because we know people have gotten cited. And also, full transmission-based precautions must be applied based on the Michigan surveyors. We've been discussing this with the department, but they have not moved from their position at this point, even though we keep getting messages from CMS Central Office that all of this is not necessary, but still we have not seen any change. And we believe that this is one area that non-nursing home settings can easily deviate from nursing home guidance. You can just follow the CDC recommendation for placing persons who are coming and going in some sort of observation area, but it's not clear that you have to isolate them with full transmission-based precautions or anything like that. So I don't see any reason to suggest that non-nursing home settings do the same thing as the nursing homes have to do here. One of the things that we're very happy to see was that when we reviewed the Coronavirus Commission report on cohorting, It identified some of the same concerns that they had and we have over visitation and its impact, because isolating for unnecessarily also causes all of the terrible and bad outcomes that lack of visitation has. It's the same thing. It's lack of visitation in another form. So with a recommendation going to CMS that it is important to rebalance this, not only for visitation, which they've already started to do, but also for cohorting, to rebalance well-being with the infection control requirements is critical. And one of the things they also suggest is that they modify the rules to require advance notice to all the residents about whatever cohorting plans a facility might have. And that felt a little burdensome, but that is also in the commission report. To date, we've not seen that CMS has acted on these recommendations as they have done with visitation, but we hope to see something soon. So this next slide includes the rest of the commission cohorting recommendations, and we're not going to go over them one by one. Pretty much they're about documentation and communication. However, there was one element that struck us a little odd, and it never occurred to me, at least before, that they found that facilities were incentivized to keep people in isolation because their payments are now higher. And what we were hearing is that there's not enough private rooms to put all these isolated patients in, and so it was very difficult. So apparently they think that some facilities are keeping residents longer in isolation than they have to in order to receive higher reimbursement. They want to change that somehow, which would be interesting. But to me, I don't think that has been a big problem. Okay, so we're going to talk a little bit about outbreaks in nursing homes. If you have a resident with a new facility acquired, suspected, or confirmed COVID, the first thing you must do is isolate and place them in transmission-based precautions. If you know that they're COVID positive, of course, you have to put them in a dedicated unit. If you are only suspecting that, then they should probably test them right away if you have access to a rapid test. Because if you don't have an observation bed for a symptomatic person, you might be okay to place the person in a single room or keep them in the same room and do a rapid test to find out. But other than that, you know, you're supposed to have an observation unit for these people. So we would suggest rapid testing to quickly identify positive persons quickly and then act accordingly to that test. And of course, use the CDC algorithm to determine if you need to do any follow-up tests. But we don't have any experience right now with how surveyors are viewing this in terms of what you have to do when you don't perhaps have an observation unit and you have someone who's symptomatic. So obviously the best option is to test them absolutely as quickly as you can. So if confirmed, if the resident is confirmed to have COVID, of course they must move to the dedicated unit ASAP. And roommates, this is all from CDC guidance, roommates should be considered exposed. Exposed persons are allowed to share rooms if they've both been exposed, but only if absolutely necessary. Otherwise, they should be kept in a private room under transmission-based precautions until they have been tested. Or they can go to an observation unit if you have capacity for that. Facilities should consider halting admissions until you know the depth of the outbreak, either to that unit or to the whole facility, depending on what it looks like. And facilities should increase monitoring of ill residents and also consider increased monitoring of all residents per shift. Of course, residents should be staying on that unit in their rooms to the extent possible until you know the extent of the outbreak and everyone's been tested. During an outbreak, staff should use full PPE on the affected units of where the outbreak is, or through the whole facility if the outbreak looks to be widespread. Facilities, of course, have to notify everyone and increase their diligence in terms of infection control and also environmental cleaning. And of course, with an outbreak, you have to start testing protocols for residents and staff and continue transmission-based precautions on all those potentially exposed persons or the affected unit until 14 days have passed without a new case. The CDC guidance also notes that if you get a new case during that time, it doesn't necessarily mean that your interventions are failing, because that case could have been incubating for a long time and could have been part of the original outbreak and not necessarily a subsequent transmission. And of course, the CDC link for all this is at the bottom of the page. For healthcare workers, the department has a guidance that states if someone has symptoms, of course, you would test them immediately and test any residents or staff coming into contact with that worker immediately as well. And if positive, of course, you have to test the rest of the staff in the whole facility. Residents who have potentially been exposed to the worker should be restricted to their room, monitored closely, and cared for using full PPE until the results are known. And continue to have transmission-based precautions for those residents, again, for 14 days from exposure if the staff did test positive. And of course, weekly testing is required until clear for 14 days. So a few more updates before we end today. We get questions sometimes about the use of N95 respirators and why they're required. And they are required for almost all residential care right now and in every setting, both from MDHHS's standpoint and CDC. N95s protect the wearer from inborn transmission as well as airborne transmission as well as other transmission. And since COVID was considered to be transmitted via droplet or contact, it does seem a bit unusual. At first, N95s were recommended softly by the CDC, and they weren't even recommended by MDHHS for anything but aerosol generating procedures. But that has since changed, and there are experts now that are concerned that there could be some airborne transmission with COVID, especially in stagnant air conditions and perhaps over larger distances than 6 feet. So we were not surprised really when the CDC about 2 weeks ago issued more precautions about it potentially being an airborne disease. But now they have taken that guidance back and saying that they had not researched it enough. So the use of N95 respirators is probably a wise precaution. Additionally, the CDC has also put out a document that includes a long list of resources for nursing homes mostly, but also for other entities to better understand testing. And the link for that is included here. It talks about all kinds of tests, when to test, their priorities for testing, where to get testing, how to work with the lab. There's a long list of educational materials in that link. Lately, there have been a lot of concerns with false positives, especially in antigen tests. CMS and CDC are both saying that in general, these false positives align with the accuracy of the tests as they understand them. And so what they're saying is that they know that the BD test only has an 80-some-odd% accuracy rate, and therefore the false positives are falling along those lines. What they're finding is perhaps a bit odd is that the false positives do seem to be occurring in clusters and not necessarily randomly across all users. However, at this point, they continue to suggest that providers simply use the CDC algorithm to determine the need for follow-up testing. And we went over that algorithm several weeks ago in one of our other webinars. It is in an earlier webinar, but if anyone needs to know how to find it, just let us know. Quidel, who is the maker of one of the point-of-care tests, is holding their training for leading age members tomorrow. The link for that is listed here. Some members have been having some trouble accessing leading age webinars through their links. And leading age has suggested that some may have to use a different browser. So if at first you can't get into one of these trainings using the link as it's identified, try doing it using a different browser. And Leading Age is also working on a follow-up training for the BD training that they did last week, but it has not been scheduled yet. They have issued a set of notes to the BD training that has recently been done, and that's included in the last link on the slide. The CDC has also put out some updated guidance on testing, and the links noted here. There really are very few changes. The main difference is that they continue to support screening of asymptomatic persons, especially with the use of rapid results testing. So it's just kind of a change in focus. The content really hasn't changed, and they continue to support screening tests for asymptomatic staff that everybody is doing every week here in Michigan. One of our members updated us with this explanation about how to think about false positives and the reporting specific to Michigan. All positive tests must be reported as a confirmed case into EM resource, and also in the NHSN website if you're doing that reporting yourself. So any additional testing within 3 months will not change that, whether that test is negative or positive. So once someone has a confirmed positive, they need to be reported as positive. The only time that you should try and correct documentation is if the lab issues you a corrected report. So again, all positives other than lab corrected reports have to continue to be treated as positive, even if it's followed up with a negative test. So these last few slides are about nursing homes only. This is just a reminder that the OIG continues to look at nursing homes very closely right now. And specifically, they're looking at life safety and emergency preparedness plans, infection control compliance, and also reporting compliance. So we just want to make sure that nursing homes are aware. We understand that you're being overseen by 50,000 regulatory agencies, but this is another one who's looking closely right now. CMS, the CDC, and through Leading Age has reported that there continues to be some problems with NHSN reporting, and they're thinking that it's mostly user error. So they're encouraging all nursing homes to review the tables of instruction again, check your data. They are planning on adding some information about flu vaccines to the data requirements, but we're not sure yet if CMS is going to require that as well. The CDC also encourages everyone to complete a full application for use of NHSN beyond the one they did in an expedited manner just to obtain access for COVID reporting. So we're not sure about whether or not CMS is going to require flu vaccination data, but I think they might. And they also want you to, and I'm not sure what the point of this is if you're already using the database, but they want you to do a full application, which is a lot more complicated than the one that was expedited in order for everyone to be able to access COVID reporting. Lastly, just a note that we found this interesting research study where there was a correlation between 5-star base quality findings and the risk for COVID outbreaks. The only other study that we had seen prior to this was one in which they identified that staffing and the likelihood of an outbreak were directly related, but none of the rest of the quality indicators. But this, as you can see here on the slide, a 2 to 3-star facility had an 87% lower chance of an outbreak compared to a 1-star facility. Obviously, 1-star facilities had the highest chance of an outbreak, and a 4 to 5-star facility had a 94% lower chance of an outbreak. So if you want to review that, that study is in the MMWR for last week, and the link for that is there. Okay, so let's see if there's any final questions.
Yes, I'm just going to get right into them. We have quite a few. All right, so this one is pretty long, so just forewarning you. Any clarification around those going out for appointments that have to return to TBP precautions? Can they go back to their private rooms and be under TPB for 14 days? If we put everyone who goes out in a separate unit location, they will take up all the beds in our yellow zone that we use for new admissions, and they will be taking up 2 rooms, their long-term room and the new TPB room in a separate space.
My understanding, and we've not really taken on this specific question individually, but my understanding is that they have to be in the observation unit. I think that that's what it says in the CMS guidance. I don't know if anyone has gotten in trouble for not doing that, but they've gotten in trouble for not putting new admissions from the hospital in a dedicated unit. We can ask that question. We have not gotten a whole lot of positive response about this issue at all from Laura. We've gotten better responses from CMS, but they've been kind of squishy in terms of, well, they don't think all these things are necessary, but it depends on the situation. And of course, in Michigan, every situation requires that level of precaution. So I don't have a great answer here for you, but my understanding is that they're supposed to be in a dedicated unit, and I know it's almost impossible for you all to do that.
Can you share what surveyor is citing for the isolation for new admits, or at least the region where the citations are happening?
Southeast Michigan. I don't know the surveyor. I know where it happened. And by the way, Margaret Chamberlain is going to join us next Wednesday and talk a little bit more about what's being cited in her experience related to COVID. So that's maybe a question we can ask her as well.
So with the return from an appointment, a resident must be in isolation and the staff members have to wear N95s?
Yes. That's my understanding in terms of practice. It's not written anywhere, but that's what the surveyors are saying.
Did you say assisted living new admissions don't need to be quarantined?
No. I would say they should be quarantined based on the CDC guidance. But remember, there's very little direction for non-nursing home facilities as there are obviously for nursing homes. Nursing homes have an awful lot of musts. The language for assisted living level, HFA, AFC, pretty much says, the department says you can consider putting them in isolation, depending on what you think the needs are. The CDC recommends it. And I would go by that. When the CDC recommends something without any qualification, I would consider that a rule. So I would follow the CDC guidance and kind of look at the department and see what they think about it. But it's the CDC really is the one with the broad requirements that will help facilities know what to do.
All right. Do new admits, readmits, people returning for appointments in nursing home qualify for increased reimbursement, or is this only for patients with a confirmed COVID?
I do not believe that they qualify for any increased reimbursement.
Okay.
To be honest with you, I have to throw this out there. I'm not that familiar with the reimbursement guidelines as they are right now, so I would have to look at that. But I've not heard that they are.
Okay. Is it a requirement for SNFs to have a point of care machine if results can be obtained within 48 hours?
No, if you can get your results in 48 hours, there is no requirement that you use a point of care machine. However, there is some tendency to want to move that to 24 hours. And if that's the case, that might change the world. But right now, the requirement is 48 hours.
Okay. Could you speak to the MDHHS guidance issued on the 15th, available options for COVID-19 testing in homes for the aged? Do you interpret this guidance to mean all ALs must or should implement mass testing? Also, do you read the memo to state only 2 weeks is required in addition to new admission and new hires, or is this testing ongoing like SNF?
Okay, well, I read it as a should, but it's a real should. I mean, I think that if there isn't concern about the lack of information about what's going on in assisted living facilities, I think that testing and reporting are important there as well, because we know that there have been some outbreaks in some of the facilities. So I think it's a should. It isn't a must, though. It's strongly encouraged by the state, but not required. And I didn't get the second part of that question. Can you reread the second part again, Blake?
Yeah, give me 1 second. Also, did you read the memo to state only 2 weeks is required in addition to new admission and new hires, or is this testing ongoing like SNFs?
I would think that I would look at your local, what's going on around you. I would look at your county positivity rate. Since you have the option to consider how important it is, I would use that to determine how much testing you might want to do, and if you want to go ahead and do it weekly. If you are in one of those really low, and some of our counties have really low transmission rates, case positivity rates, let's call it that, test positivity. But some of them have relatively high, I mean, especially the urban areas. So I would look at your rates, maybe confer with your health department and see if they think that ongoing testing is needed. I think it depends on what's going on around you, because the more community transmission you have around you, the greater the likelihood that your staff might be bringing it into the facility.
Okay. Is there any hope for opening up communal dining? Our residents are exposed to staff on a daily basis. Excuse me. Hold
It
on.
depends on whether or not.
I had to stop. I had to cough. I had to mute myself. Is there any hope for opening up communal dining? Our residents are exposed to staff on a daily basis, which puts them at a higher risk than exposure to one another. We could seat 2 at each table across from one another. This would make a huge difference in their quality of life, potentially a bigger difference than outside visitation, since meals happen 3 times every day.
Yes, and we agree with you. And we see, obviously, there are signs of that for nursing homes because the updated visitation CMS guidance, QSO 2039, specifically states that you can put people in the same room for dining as long as you have, you're taking care of all of the safety precautions. The problem is that, first of all, no one's paying attention to that guidance just yet. Hopefully they will for nursing homes shortly. And then the additional issue is that the state is still in charge of what other levels of care can do. And so unless the state loosens that up as well, if you're an ADC, HFA, or assisted living, you're going to be stuck with no communal dining. Because when we ask them, they tell us that there's no qualification to that. As far as they're concerned, there's no communal dining. But we're hoping that the state takes the CMS guidance to heart, reads the Coronavirus Commission report, and understands that these very restrictive guidelines are not helping our residents, and in fact are, detrimental to their well-being. And we keep trying to put that in front of their face, but so far we've not gotten anywhere in that respect, at least.
Okay. Seems very contradictory that a resident who goes out to a doctor's appointment requires 14 days in observation status and TBP, but family visitation is allowed.
I think the whole thing is contradictory sometimes. So yes, I agree with you. There's conflicting, there's no alignment here. It doesn't flow. And I think I would wish all the entities will work together and make everything flow better in terms of rationale and sense making. I'm concerned that they'll have to open up nursing homes to visitation, but not any other setting. I mean, that's a possibility too, which is, yes, it's confusing and conflicting.
Can you please clarify, if no resident case exists, must staff wear N95 masks on units where new admits are cohorting for the first 14 days, or are N95s only required if suspected or confirmed cases?
The CDC guidance is a little bit looser regarding this than the state guidance. They identify that N95s are preferred pretty much for all COVID care right now, not just observation and COVID positive care either. For all nursing home care is preferred, but they also identify that there are shortages of N95s, and that a mask will do if you're trying to preserve N95 respirators. But the MDHHS guidance, which we went over maybe a month or two ago, and I can provide that link, pretty much says N95 is required for all care, which was a big turnaround for them, because in the beginning they didn't require N95s for anything but aerosol generating procedures. But now, and in fact in all settings, N95s are required for all care. So considering that there is an airborne element to this, and you don't know who is going to test for positive at any time, I think that it is basically a safety precaution in order to decrease the possibilities of that transmission. And the CDC prefers it, and the state requires it.
Okay. Does the 14-day quarantine after going out for an appointment apply to IL and AL?
No. No, that is one of the things that there is no guidance that says that at all for anything but nursing homes.
Okay. Was reading this one. It looks like it was another question about N95, so I'm just gonna skip that one. Where can we find the CDC guidance related to about 14-day quarantines for AL when residents return from outside appointments? Today we require it, and we would really like to stop this if not required.
There is no CDC guidance that I'm aware of about people moving in and out of facilities for medical appointments at all. And in fact, the CDC representative during a conference call about 3 or 4 weeks ago stated that there just isn't enough data saying that that's important. The problem is that the guidance is coming from CMS in one of their QSOs. So that piece, that's one of the few pieces that shouldn't apply to any other setting but nursing homes. So I would not do that if you're not a nursing home.
Okay. So all new admits need to be on a completely separate unit from all other residents for 14 days. What if you can't do this? Are you just supposed to not take new admits?
I don't know. I don't know how a good answer to that. I do know that one of our members got an immediate jeopardy citation for not separating. Now, let me reframe that a bit. It might be because they had the residents spread out in the facility. In other words, so if you had a new resident on this wing, you might have a new resident on another wing. They had them in private rooms and they had them quarantined, but they didn't have them together. And it might have been that together issue. If you only have one, you might be able to get away with, you know, a private room with some careful precautions. But they got an immediate jeopardy, and when I was talking to their legal team, they didn't even think that they were going to be able to appeal in a positive way to that case. So the state is going to cite for that at this point, and I don't know. We can continue to try and work with them, but they seem bent on that right now.
Okay. Was there guidance for testing a resident in a SNF who went out for an appointment, or is the guidance only for the 14-day observation unit?
The guidance is only for 14 days of observation. There is no testing requirement, although I believe that the CDC at one point suggested that if you have someone going in and out, such as a dialysis patient 2 or 3 times a week, perhaps testing would be better than isolating. There was some discussion about that during a conference call, but it didn't change the CMS QSO guide for nursing homes at all.
Okay. Do those in the dedicated unit for new admit, readmits, appointments, dialysis, etc. require dedicated staff as well?
I cannot recall specifically that it says that anywhere. I had always assumed it. I can look around in the guidance, but I don't know that it says specifically that dedicated staff would be required there. I only know that dedicated staff are required for the COVID positive unit.
All right. Do you have a recommended training we can use for volunteer visitor monitors who have to be trained in infection control?
No. I did have a discussion with one of the members when that guidance first came out, and my suggestion was that you put together a protocol based on the guidance and based on basic infection control, the things that they need to monitor, and then train to that. Some of the CDC trainings are very basic on hand washing, etc. Those might be useful, but off the top of my head, I can't tell you where they are. I would probably look at the QIO CDC trainings that are on the QIO website, and the link for that is at the beginning of the cohorting slides here. There is a long list of trainings that are available, and CMS also has some basic direct care level trainings that are available that I would pick and choose from based on need. But our suggestion was that we encourage people to develop their protocol first, and then from that protocol what they need to be monitoring, and then define a training program based on that. There is nothing specific to it, no.
All right, thank you for that, Deanna. That actually looks like it was our last question that just popped up. So we would like to thank both Deanna and Dalton for all the information. We would also like to thank all of our members and participants. I believe we got up around, I think it was around 95 members that took time out of their busy schedules to join us for today's webinar. We appreciate everything you guys do each and every day to support your staff and provide quality care to your residents. We are grateful for your continued support, and we are here for you when you need our assistance and resources. If you have any other questions that pop up or something that you think of after the webinar, you can feel free to shoot those over to either Dalton, Deanna, or the Safe and Calm email, and we will make sure to get those answered for you. Other than that, I hope everyone has a great rest of their day, and we will see you guys at 11 a.m. on Friday. Deanna or Dalton, you have anything else you'd like to add?
I have one thing. That call for Thursday was actually already rescheduled for the PRF funds between Leading Age National and CMS. So hold tight on answers for that, and they are looking to collect any questions you may have about the provider relief funds at the national level. So if you do have any questions that you want Leading Age to ask, please send those over to me and I'll compile them and send them over to them.
All right. Thank you, Dalton. And everyone have a great rest of your day.
Thank you all.
Have a great day.